I think Dr. Angela Brown-Burke looks like she's volunteering. So can we ask her to just quickly say a word of prayer for us? Thank you.
Sure. Heavenly Father, we come to you once again, asking for your guidance, asking that the deliberations that we make today will be done in the interest of your people. You know the challenge that is before us, both in terms of the pandemic and in terms of just making sure that we move together as one team, understanding that at the end of the day, this is about the welfare, well-being, and health of the Jamaican people. Again, I ask for your blessings and your coverage in your Holy Son's name.
Thank you very much. Thanks a lot. All right, in terms of those who are present, and apologies for absence, I'm just going to do a quick roll call. I think it's necessary because of the nature of the setup here. I see a lot of names on the screen, not all I recognize. Let's start with the members of the committee. I see member Morris Guy, I believe, yes. Thank you, member Angela Brown-Burke, who spoke earlier. Member Norman Dunn, member Mark Golding,
President.
member Marisa Dalrymp Filbert.
I'm here.
Very good. I don't see member Holness. Is there an apology for her? No, okay. And I don't see member Horace Daly. Is there an apology for him? No, okay. And
He'll be late.
He'll be late. And then member Marlene Malahoo Fort.
She's there. She's connecting.
Okay. Madam AG is connecting. All right. And that would constitute the members of the committee. So far, Horace Daly and Juliet Holness are not here as yet. I see member Malahoo Fort is connecting. In terms of the other members who are specially invited to the committee, I can see the Ministry of Labor and Social Security represented by the Permanent Secretary. Am I correct? Unmute your mic.
Trying to unmute. Yes.
Okay.
Thanks.
Great.
Yes, we're here.
All right. Excellent. I see you, member Malahoo Fort. Thanks for joining us. And then I see. Is there any other member from? I'm not sure who the other persons are as it relates to the committee as presenters. But the Ministry of Labor is certainly there. Is the Ministry of Local Government represented?
Yes, good morning. Treka Lewis from the Ministry of Local Government Board of Supervision.
Okay, thank you, Ms. Lewis. And then in studio here we have at the ministry here we have the Permanent Secretary, Mr. Dunstan Brand, the Chief Medical Officer, Dr. Jacqueline Bisesa McKenzie, and Ms. Fabia Lam, who is operating out of the office of the Permanent Secretary. All right, there are two other. There's one other person I want to mention who will make a presentation, and that is Mr. Paris Leowai from Mona Informatics. And he's going to make a presentation on vulnerable communities, something that has occupied a discussion. I know member Mark Golding has been speaking about that. And there is the advisory team did a presentation to cabinet yesterday on mapping of these vulnerable communities. And I'm going to ask him to make that presentation. I'm not sure if he's online now, but he certainly will join us at the appropriate time to make that presentation. Okay, so if that is...
MJ raises hand.
Who's there? Sorry.
MJ.
Yeah, that's me. Chair, there are some other people listed in the participant list. Can we have them identified as to who they are and why they're here? Just so we know who is here. I see... Yeah, there are a couple of names. If you touch on the participant list, there are a couple of names. Obviously, not talking about Hansard. We know why they're there and public relations. Yeah.
Well,
with
Some
other
of them
people.
some of them are members of the gallery, I would think, as it would be in the regular parliamentary meeting where anyone can sit in and observe. I know that Dr. Dan Thorburn, who is online, it works out of my office, and I'd ask her to sit in just to observe. So she's there. Who is Sharon Wayne Campbell? Chevon Wayne Campbell. I'm only recognizing the name. I'm not sure. Wayne Campbell.
Member of the media, Dr. Tufton, Chevon Campbell from Nationwide News.
Okay, so that's media. Sorry. All right, great. Of course, the recording secretary is online. Aladden Love. Aladden Love. Or
Yes,
AL.
hello, hearing me?
Yes.
Right, I'm from CVM TV.
Okay, great.
Right.
And then Alicia Dunkley Willis. Miss Willis.
Hello.
Yes, Miss Willis.
I'm sorry, I was driving and I was trying to manipulate, but I'm from the Observer, yes.
Okay. Okay. So, Member Golding, most of these persons seem to be media personnel. And then I see Cheryl Gibson. Cheryl Gibson.
He's from the Parliament.
Parliament.
Parliament. Okay, great. And then Chesson Brandon.
That's the clerk. That's clerk to the committee.
Move that up for me, please. That's more the names. I'm just trying to maneuver the names. Sorry about this, guys. But okay, and the rest of the persons seem to be media. I see PBCJ. I see
Donique Weston.
Donique Weston. Who is that? Donique Weston.
I'm with media, IRA FM.
IRA, okay. All right. Are there any other names? I see public relations and Treka Lewis. Treka Lewis is also media, right?
No, local government.
No.
Local government, right. All right. So is there anyone who else who wants to recognize themselves who hasn't been mentioned?
Minister, are you hearing me? This
Yes,
is
I am.
Marlene Malahu Fort.
Right. I'm hearing you, Member Malaport, and I did recognize you. Thanks for joining
Very
us.
well. Yes.
So basically what we have then, Member Golding, in response to your question, seems to be media and in at least one case, an observer. So we're trying to be virtual, but at the same time accommodate in the normal procedures of these sittings.
Thank you.
Thanks a lot. Thank you very much all for being on board. Right. Just
I raise
like,
my hand.
Anila McCarthy, committee coordinator, sir.
who is that? Sorry.
Anila McCarthy, committee coordinator.
Okay. All right.
Committee coordinator.
Committee coordinator. Thank you. All right. So just to be clear on the proceedings, just to be clear on the proceedings, remember now that only committee members are allowed to speak, and we follow a particular agenda. So all others who are online will observe in the normal course of how these meetings are conducted. So no questions from the media and so on. Okay. All right. Thank you very much. So can I go quickly now in?
No, Minister, I raised my hand.
Oh, sorry about that. Yes, Member Brownberg.
Sure, I was just inquiring. Last meeting, we did not get a copy of the presentation from Dr. The last presentation, and I did not see it in the documents that were sent today. So I was just wondering how we were treating with that.
Okay. We'll make a note of that. That's a presentation that was done by Dr. Webster Carr. All right, I'll speak to her about it. Oh, I have the team here, so I'll mention the PS will make a note of that and we'll circulate. Thank you very much, member. Okay, I see Mark Golding, member, have his hand up. I know he made a contribution already. Are you seeking to make another?
Oh, my hand is not up, sir. That must be the same hand that was up before, but you addressed it satisfactorily. Thank you.
Okay,
Member Guy, there is a way to raise your hand other than raising your literal hand.
Yes, I believe he's aware. But Member Guy, just click on the hand. on the on your screen, and then you can make your contribution. The others though, you need to take down that the hand that you have raised, unless you need to make another point. Otherwise, it gets confused.
I need to, Chairman.
Yes,
just
Member Guy.
matter. The minutes, I understand the fact that the meeting is basically been held 5 days after the last one, but the minutes coming in at 9:45 this morning, we need to ensure that these are properly done by the clerk so that we can have them to have a proper read before we have the meeting.
Got you. And that's a useful contribution. So I'll ask the clerk to take note of that. In fact, I only got my copy a short while ago too, and quickly try to go through. Nevertheless, can we just quickly run through the minutes in keeping with the agenda, and you can make a note as to if you want to raise any item. All right, so can I start with page 1? Page 2. Page 3. Page 4. Page 5.
I raise my hand on page 4.
Okay, go ahead, Member Brownberg.
So I think it's the second paragraph that begins Member Brownberg. But I'm looking at the last sentence in that one, where it says Member Brownberg pointed out that many persons were unclear what they should do if they had symptoms. And I went on to suggest that we needed to have specific public education messages that would deal with that gap.
Okay, so you're adding to the point about the public education.
I added to the points. I'd like it reflected.
Yes, that's what I meant. Okay.
Okay.
All right. Thank you very much. Okay, page 5. Page 6. Page 7. Pages 8. Pages 8, the first paragraph where the chairman clarified that there was no difficulty in testing persons who were quarantined or the communities that were in quarantine, and about the testing protocol. Is it here? Trying to find where I needed to clarify something, because I had made the statement for the record last time that we were only testing symptomatic persons, and I would like to correct that. I don't know if this is the place to correct it, because having spoken back to my team, I was reminded that the protocol had extended to asymptomatic persons where there was contact tracing to suggest individuals had come in contact with a positive case. The CMO is here, and I think that more accurately reflects the protocol. In other words, we do test asymptomatic persons not showing symptoms, but those were persons who are in close contact with a positive case, with the index case or a positive case. Just for clarity, and I think it probably could go on page 8, the first paragraph where I spoke to the testing in communities, and that is all right. I'll see if it was mentioned specifically somewhere else.
Chairman, I have my hand up.
Yes, Member Guy.
Chairman, I think this would not come into the minutes because this was what was actually said. So any correction that needs to be made has to be done in the body of this current minutes for this meeting. So I don't think you can make it as a correction.
Well, it it was said in the last meeting, so it would be a matter of record, which I'm trying to correct.
I know, but this record will correct it.
Yes, okay. All right, well, Member Malawu Fort, you have your hand up.
Dr. Tufton, I'm not sure how to put my hand up, but I want to ask a question before you start your presentations also.
All right, we're still on the minutes, Member Dalrymp of Filbert. So
Right.
you want to finish?
Right.
And then,
Right.
Member Malawu Fort has it. You want to make a point on this?
No, I just want to find out, how do I put up my hand? Is it just to tap?
All right. We have our IT person there. You want to tell us?
You could. Sorry, I was trying to help.
Go ahead.
You could click on participants at the bottom of the screen,
Or the top, depends on where you have it.
or wherever participants fall. Then you will see at the bottom of the list of persons, mute me or raise hand.
Exactly. Very well. Listen, this is a learning experience, so we can afford to be a little what should I say? Accommodating.
I
just learned.
I know.
I'm using my phone, Dr. Guy, and I'm not seeing that.
You're looking at the list of participants?
She's in her phone.
She's in her phone.
Yeah.
She can still see the participant.
It should be there in your phone also.
At the side of her phone.
Remember Dalrymp of Filbert. Until you, when you figure it out, otherwise just shout. We will recognize you. All right, Member Malawu Fort, you have your mic on mute, so I can't hear you, even though I know your hand is up and you're trying to speak.
Are you hearing me now?
I'm hearing you now. Yes, go ahead.
Very well. I was saying that to the extent that what is recorded in the minutes accurately reflected what was said, but it is not an accurate reflection of what actually is happening, then you would have to indicate that although that had been said, you're clarifying that what exists is, as you went on to say, which I think is the point Member Guy was raising. So the minutes can't be corrected to reflect that although that was said, it is not in fact. If you said you went on to say something else, which was not captured, then it can also be reflected as a correction.
Okay,
but it wasn't said.
Thank you for that clarity. Well, it was
I wasn't there, so I can't determine whether it was said or not, but just how it can be captured in the minutes.
It was said, but it's not clear in the minutes, but except for that section which spoke generally to testing, which is why I raised it. But either way, it's fine. I mean, we'll ensure that it's recorded now. Thank you very much. So I am on page 10, 11, 12, and then finally 13. Are there any corrections? I'm assuming there's none. So I'm going to ask that the minutes be confirmed. Can I get a confirmation from, thank you, Member Guy, if that's all right with you. And seconded by Member Dunn, who was also present. Thank you, unless you have an objection. So matters arising from the minutes quickly. Any matter arising, I see Member Malawu Fort's name up, or hand up, sorry. If it's not, could you just take the hand down? I know you had made a contribution before. And can I go to Member Morris Guy?
Thank you, Chairman. Just for clarification, it's matters arising. The Dr. Webster Carr indicated that the capacity, I don't know which page it falls on in the minutes, because I'm reading it on a different screen, that there was the capacity of 1,260 per week at the National Influenza Laboratory. Is that correct?
1,260 what, sorry?
Tests, sorry, my apologies. 1,260 tests was the capacity at the National Influenza Laboratory. 1,260 tests currently, the capacity currently is 1,260 tests.
I don't know that that is the case. So it's
No.
180 per day.
180 per day.
180 per day.
Yeah, that's 12.
So it works out to 1260 per week, right?
Yeah.
2 shifts, 90 per
Oh,
shift.
they're on 2 shifts now.
Right.
Okay.
All right.
All right. Sure.
Dr. Brownberg, Member Brownberg, you have your hand up?
I do. And just very quickly, one is to say that the message about the possibility of wearing masks for the public, I think, has been welcome since we had the last meeting. And I wanted to also make the point about the continued public education that is necessary, since we now are moving to that in terms of putting on, taking off, and the need for other precautionary measures to be continued.
Thank you for that.
And then just the last point I wanted to ask, again, just a clarification. In the last meeting, Dr. Webster Carr had spoken about, again, the capacity for ventilators this time at peak. And I noticed that when we give those numbers, we actually speak about only the new cases, but I wasn't sure if the assertion of having sufficient had taken into consideration what would have been the cumulative number at that point and where we were in relation to that.
Okay. I just wondered whether you could save that question or clarification request for the presentation that she'll make shortly, because we will make a presentation which we have queued up, and then we can get into general conversation. So we'll reserve matters arising just to clarify, but remember that the presentation is coming after. Member Marisa Dalrymp from Filbert, you have your hand up, so you've figured it out very well. Any comment? You have to unmute your mic. Your mic is still muted, so can't hear you. Or when you figure it out, then we'll come back to you. All right, so members, if there are no other matters arising, which I think most things will be covered in the presentation, and you'll have an opportunity to ask questions. I want to go right into just saying that we have 3 representations that will take place here, and we're going to try and move it very quickly. The first, of course, is the general update, which the Chief Medical Officer will do. And the second is a presentation by the Paris Leowai team on looking at mapping of vulnerable groups. And then we will ask the Ministry of Labor and Social Security, who had submitted a short report to address some of the concerns around the distribution, which came up last week. Local government is also on, so they could respond to any concerns or that may arise as it relates to local government. So we have a few things to do. So I'd love us to try and keep it very tight in terms of the presentation and keep the questions as brief as possible to ensure we accommodate all. If that is okay, I'm going to ask the CMO to just move into her presentation. Now we need to share the screen. You will see the presentation coming up on your screen, and I'm asking the technical folks to just put that up now, and then we can confirm if all is up. Getting that? Okay. Can everyone see the screen now?
Yes.
Okay, great. Excellent. You may have to minimize the, okay, good. All right, so I'm going to ask Dr. Webster Carr to quickly, Dr. Bisesa McKenzie, to quickly just run through the latest update as of yesterday. All right, Dr. Webster Carr. Dr. Bisesa McKenzie, I'm sorry about that. Anyway, tired. Go ahead, Dr. Bisesa McKenzie.
Right, good morning, everyone. You can go to the next slide.
There?
Yes. Right. Okay, so as this is actually as at the 6th of April, That was yesterday. We had a total cases, 59 cases. We have discussed, I think, at this committee that there are 3 deaths. I just want to mention here that one of the deaths that we had, although in a patient who was confirmed to have COVID, that death occurred at the time when the patient was recovering well from COVID and is being investigated presently, but is thought to have been as a result of probably some cardiovascular related incident. So we can say that the 2 deaths are COVID related, but the one is still under investigation. So you will see in some forum, you will see 2 with an asterisk, and just to let you know what that means. We've discharged 8 persons as of yesterday. So these persons would have completed their symptomatic phase, had been asymptomatic, had at least 2 tests that were done and that showed a consecutive negative result. Yesterday, we had 43 persons that were still in isolation in hospital. 10 of those persons were asymptomatic and at various stages of the discharge testing protocol. And we had 2 critically ill persons. And we really regret to say that at least one of these persons are not doing so well. And so we continue to apply all that is necessary. But we are monitoring very, very closely. Next. So the next slide is really is a slide that you are used to seeing. It's giving a breakdown of the time of presentation of the 59 cases and the time of onset of their illness, the time that they entered into the country. So we have 29 chains of transmission. That means that for the balance of the 30 persons, in addition to the 29, they are linked in some way to one of these chains. This gives you a better idea of the distribution across the island. And you can see that we have cases in 11 parishes, counting KSA as 2 parishes. And we have what we call clusters, which is where there is more than 1 case associated with an index case in 4 parishes. Next slide. This is an update on the testing that had been done up until the end of last week, where we had done 646 tests with 58 positive, with a positive rate of 9%. You can see on the graph beside that we have been consistently increasing the number of tests that are done. However, we do have a target of having up to 2,000 tests per week being done. And last week, we doubled the numbers that were done the previous week. And this week, we're aiming to at least double what was done last week. We have put various measures in place to ensure that the samples are being done. And we're following up on a daily, almost hourly basis to try to get the samples in, to make sure that we're getting samples from right across the island, from all of our facilities, to ensure that we reach our target. Yesterday, I can report that we had 72 samples coming in. That was a bit short of our target, but we haven't added the university samples to that as yet. So we're still hoping that we would have had at least 90 tests for testing today. And we're actively trying to get at least 100 tests done per day. As I said, our capacity is 180, and that is our aim at this time. In another 2 weeks, we expect that, or another week and a half, because things are going on track in terms of development of the capacity at the National Public Health Lab. So we do expect that we would increase our capacity to test. But I'm sure all the members are concerned, as we are, and we're actively working just to get the samples in so that we can get our numbers up for testing. Next There has been a lot of questions about community transmission, whether or not we are in community transmission or not. Just to remind the members that the WHO has defined four levels of transmission. We have passed through the no cases, the sporadic cases, and we are now at clusters of cases. WHO has provided guidance in terms of when it is that you say that you are in community transmission. Next slide. And we have looked at the different options, and while we're getting clarification on some of the other options in terms of numbers of unlinked clusters and numbers of unlinked cases, what we can identify with is the requirement for large number of cases from sentinel lab surveillance. Because as you know, the committee has been advised that we are doing the severe acute respiratory illness surveillance and the influenza-like illness surveillance right across the island, and these are our sentinel lab surveillance. We have our trigger point that we are looking at to say that we would be in community transmission is if we have a 5% positivity rate in any given week. What this means is that 5% of the cases that come in for routine surveillance, not the suspected cases, not the contacts, just the routine surveillance, if we're picking up 5% of those that are done, that are coming back as positive, then that would suggest that we are in community transmission. Insofar in terms of the, okay, just to look at the third column of the line of the table, you will see our positivity rate over the last 3 weeks. Now, I just want to say to the members that as the denominator increases, which is the number of cases we get in through this surveillance, this type of surveillance, then we would expect that the positivity rate would decrease. However, based on our present positivity rate, last week we were at 4.1%, where we had 2 positive cases arising out of surveillance, out of a total of 49 routine surveillance cases that was done. Next slide. This, up to last week, we still remain on the 8-day doubling per week track, which means that for every 8 days, we have been doubling the number of cases that are positive. We still remain on this track, but however, we would want to say that, you know, at any point, anything could cause an upturn in this trend. And so all the measures that we have in place, we believe are contributing to keeping us on this level. And but we do have to prepare, and we're constantly preparing just in case we get an upturn on this and we end up with a 5-day doubling or a 3-day doubling or even worse. This is just looking at the same information again. You're seeing the table here as well as the graph that shows the numbers that we, using our present numbers of 59 cases, which was what would be the doubling over the next 2 weeks, what this would look like. Again, in terms of our preparation, in terms of preparing for the number of cases that we would have in terms of critical care beds, we are on track with this. Again, if it is that we do keep on the path that we are on, then what we have planned, it would be more than adequate, although we continue to try to increase our resources and to have more put in place just in case there is a change of that trajectory. So a member had asked about the number of ventilators, and I don't have a slide on it, but I would just comment on it here to say that, yes, we did consider the number of ventilators that are presently in use in the system, and we were not projecting for those to be used for COVID. We tried to acquire ventilators to deal with any surge on top of the usual utilization of ventilators. So we did not factor the 35 ventilators that we have across the island, of which 26 we can confirm are presently in good working condition today. We did not factor the use of those ventilators in the surge planning for COVID. So our initial plan was for us to get an additional 40 ventilators. We are in the process of achieving that. We have in Ireland 3 plus about 30 now of the 40, and we would receive another 25 at the beginning of May. So we have really surpassed our planning, and that really conveniently took into consideration that we had received we're on the verge of receiving the ProMac ventilators, which we now have received. So that gave us a further boost to our capacity to enable us to be able to meet any increase in demand that there is. We have, through donations that have been promised, and some have already been initiated through our partnerships with other governments and entities, have secured more than this 40 plus the 23 from ProMac. So we are in the process now of building the capacity within the hospitals to be able to receive these additional ventilators.
Okay. What do you want to do? Okay. All right. I'm going to ask the PS just to comment on the field hospital that cabinet approved yesterday. You want to say a few words on that, please?
So while we are still on the 8-day trajectory, oh, thank you, Chairman, and good morning. While we're still on the 8-day trajectory, we still have to plan for any possible outcome. And part of the COVID response plan is the implementation of a field hospital to respond to any upsurge or the surge. So that I should change the caption here. It's the National Arena that we are proposing, and the National Arena is to be outfitted as a 72-bed field hospital, and this is just based on the reconnaissance visit that was made by the team from the Ministry of Health and Wellness, the Ministry of Sports, Gender, etc. And the personnel management of the National Arena. We looked at what the dimensions and the specifications of the existing infrastructure were. And we looked at our scope of work in terms of what was required for us to establish a field hospital for the national arena, as to transform them of National Arena as a field hospital. Next. So this is the outline of what has been designed. We are finalizing this design based on consultations. Just some minor tweaks will be required. And then next, the financing is $182 million. Cabinet has asked that they lead on the implementation of this action with the Jamaica Defense Force. Next. Overall, the budget, we have now received $2.8 billion from the Ministry of Finance and the Public Service. And we have expended $2 billion of that. We have approximately $752 million that will be utilized to activate interventions over the next 2 to 3 months. And the renovation of the hospital, of the National Arena, forms part of that discussion. In terms of our stocks, we 9 million gloves, face masks, face shields. We have 80 face shields that are to come into 80,000 face shields that are to come in island between this week and next week. We now have 500,000 masks, N95 masks that have landed in the island yesterday and are being cleared today for distribution. And we are also have discussions with the MAJ for distribution of 100,000 of these N95 masks through the MAJ to the private practitioners so that they have the necessary, some of the support that are required to assess and see patients. Yeah.
All right, thank you very much, PS. So, ladies and gentlemen, we of the committee, this represents the latest, except for the last 12 hours or so, in the work that is being done by the ministry. And all of this information, of course, guided by the cabinet, is taking place. And I put that before you as members of the committee by way of update as to where we are in the operations as well as the planning for responding effectively to the COVID challenge that we have. All right, I'm trying to bring back all on screen. Okay, we're on screen now. And I wanted to find out, should we go into the next presentation on vulnerable groups, or do we interrogate this presentation first? I'm just wondering because they are kind of connected. And you may be in a position to have a better picture of what is happening if we got the Paris presentation. What our members.
Chairman, I would rather just ask a few questions here. Just clarification.
All right, go ahead, member guy.
Thank you very much, Chairman. CMO, could you give us the breakdown of the ventilators that you just told us a while ago? Because you said that the 26 functioning ones of the 35 that are currently in Ireland were not considered in the acquisition of the new ventilators, and you're looking at 40. Now, you said that we have 30 in Ireland now, and then you said another 25 by the beginning of May, which would take us to 55. But then you also said that there are 23 ProMac and 40 would make 63. Can you reconcile that difference for me?
Okay. All right. So there is some mixing up of the ProMac now there as well. So we have out of the 30 that are presently ordered by the NHF, which is a part of the 40 that we planned for acquisition for this response. We have received six so far. We are to receive a further 7, 6 and 7, 13. And then the balance we are supposed to receive at the beginning of May. So that would take us to 30 there. Okay.
So it's not that you're expecting 30 at the beginning of May. That's the total amount that you'll have.
Some of them had come, and I guess I did not change my numbers because the 6 we had expected 3, then 7, then 20, then 25. So actually we got 3, then we got 3 more, and then we are supposed to get 7 more, and then the balance. So this is really the delivery schedule has changed on us depending on how they can get them in.
So how much do we have now of that amount that you are seeking?
Okay. So in addition to the 6 that we presently have in Ireland out of what was ordered by NHF, we received 23 through ProMac. And really and truly for that 23, there is an additional 3 transport ventilators that were also received that I did not mention previously. So it's really 26 that is coming through ProMac.
But in terms of the other, the 40 that you refer to, how many are in Ireland?
Six of those.
All right, thank you.
Mhm.
CMO, I see I noticed that there is an order hydroxychloroquine. Have we adopted that protocol for treatment yet?
No, we have not, member, because we have had quite a bit of discussion with the very senior team from across the island had been drawn together to have the discussion and to do the review of the documents. We have also taken into consideration the recent documents that have been put out by the WHO in terms of their own review, peer review of the information that has been put out. Because of the very high incidence of cardiac related issues, the WHO has recommended for not to put hydrochloroquine in present protocols. So we have not put it in the protocols. However, there are studies that are being put together through WHO, the Solidarity Trial, where for cases that we think would benefit from all things considered, and we have to have a careful consideration of the premorbid conditions. It's a very tricky decision as to the patients for this to be utilized in, because the more severe presentations would be the ones that you would want to try this in, but then that is where you have the highest incidence of the possibility of poor outcomes. So only under trial guidance and with the stipulations, very rigid stipulations, as you may know, member, that would have to be put in place for the monitoring, the selection and monitoring of that kind of patient that would be used. Only in those situations we are presently recommended. So Jamaica has...
So we have not well recommended that yet.
Is not in our guidelines.
All right, thank you, member.
No, Minister, before you go, can I ask the CMO to look at what is happening at Maypen Hospital as it relates to the question I asked a while ago? Because patients have been getting that. And you need to have a discussion with your team, because you cannot have a situation where the team is acting on its own volition in terms of doing a trial without approval from the CMO or the ministry.
Take note of that, member, to follow up on that.
Please.
We'll have to check to validate that, however, member. I know that member Holness, Juliet Holness, is on the meeting. Welcome, member Holness. All right, let me go quickly to member Brown Burke. And member Guy, can you just take down the hand, the electronic hand that is? Thank you.
Okay, so I just had two quick points I want to make. One related to the report in terms of just the numbers that we give. And I believe it would be helpful if, I know we now have the total tested, which is good, but it would be good if we could also include whether or not individuals who are being monitored or in quarantine, let's say home quarantine, if those numbers are included in the reports that we give, so that we have a broader view of the number of persons that are actually being monitored, because I believe that could be one of the areas that cause concerns in terms of whether or not we have our eye on the broadest group that we could.
Thank you.
So that's one. No, I said two. So the second one.
To add something to
that.
Member Holness, just mute your mic and just use the hand signal if you have a point to raise. Otherwise, it gets a little disjointed.
I wanted to add something to what Member Burke is asking.
Yeah, but don't use your physical hand. If you look
I'm not seeing any hand on mine.
On your knob there, yeah,
Once
there's
more.
one there.
Okay,
Just-
hold on. Let me search. Okay, I can find it. That's the thumbs up hand.
Yes, same one. So just put it
Okay,
there and then
let me
you
put
go
it
in
on.
you go in a queue and then we'll come back to you. Let Member Burke just finish her thing and then we come back to you. Member Brownberg, quickly go
Sure.
ahead.
And then just very quickly, the second point I wanted to ask really is about the testing protocol that we had seen in the presentation the last time around. And if my memory serves me right, the position was that we were testing symptomatic healthcare workers. And I wanted to ask why we were doing that, because I've noted that elsewhere, there is a kind of schedule on which healthcare workers who are exposed to patients with COVID are tested. So those are the 2 points I wanted to
Thank you very much, Member Brownberg. Simo, you want to quickly go through that quickly?
Right. Thank you for the question. With regards to the healthcare workers, we have recently put out the protocol in terms of the assessment of the risk exposure. So we are now pulling together the infection prevention and control committees in the hospitals and in the health departments so that all our healthcare workers can be monitored and tested where appropriate. So it is a situation where we are going to have 2 kinds of testing being done for the healthcare workers. The healthcare workers who become symptomatic will be tested, as well as the healthcare workers who are exposed, who may not have symptoms. So the assessment of the risk exposure, the tool has been sent out. We have looked at both the WHO guidelines and the CDC guidelines and have pulled together our guidelines from that. And I think that we now have a comprehensive method that we are now pulling together the IPCC committees within the hospitals to make sure that it is monitored through that channel and reported into the National Surveillance Unit so that we can report comprehensively on this. So the risk assessment tool member did go out last week. And so we are doing the sensitization of the infection prevention and control committees. So we do recognize that prior to that, a lot of different things were being done, but we are trying to get it organized in a way so that there can be accurate representation within the surveillance unit so that it can be reported on comprehensively.
Thank you very much. Can I get, I see Mark Golding and then Norman Dunn and then Miss Juliet Hollis.
No, the second issue.
Member Golding.
Thank you, Chair. I think Member Brownberg was just asking about the second issue, her second issue. I would defer for the answer for that.
What was the second issue again? The testing protocol about healthcare workers. Your mic is mute. Can you unmute your mic, please? Not hearing you, Member Brownberg.
Oh, I'm sorry about that. Which was really the first question, which is really about making sure that when we give the report, we also cover those individuals who are either, I don't want to call it, whether it's in quarantine at home, but those that are.
What categories of patients or persons would be, what's the plan for that? Who would be interned there, so to speak? How would it be used?
This facility would be for, at most, it would be an isolation facility. So therefore it would be confirmed cases and at most mildly symptomatic persons. We are reserving the hospitals for the moderate to severely ill persons. And also we would have to take into consideration even the mildly symptomatic persons who have several comorbid illnesses that would put them at risk for severe illness. So those would also be prioritized to be put into the regular hospital setting.
Thank you very much.
So Chair, you had made a call for space for persons who are in the recovery phase and are not very ill, but are, it's not intended to use it for that then. That's a different thing.
That's a different thing. Of course, you know that as soon as we get the resources in and the demands are there, then we will have to adjust as time goes by. But right now we are envisioning that persons who would have gone through the hospital phase whether it would be in the regular hospital or in a field hospital setting, that were now asymptomatic, we are envisioning a different setting to put those persons in.
And let me just add on that we have actually secured some space in each of the regions where those facilities, the convalescent type facility, are actually being repurposed for that reason. So in Montego Bay, there we have 50 odd rooms. In Southern, we have about 40 in 2 locations. In Kingston, we have about 30 or so, and working on a few others. And in Nero, which is St. Ann, Portland, St. Mary, we're now in the process of discussing 2 facilities. So that is in train, and we have some confirmed already. We can give more details on that. Thank you very much. I recognize Member Dunn, Norman Dunn. Member Dunn, you just have to unmute your mic and you can speak. Yes, it's unmuted, but I'm not hearing you. All right, until you sort that out, Member Holness, your time. Unmute your mic and speak.
Chairman, and CMO, I just wanted to make sure that not just for myself, the rest of the public is absolutely clear. All our 58 positive individuals, I think, or probably about 57, I think 2 persons have been released. All of them, where are they physically located? So once you're positive at this exact point in time, where would you all be located? Because I found some of my constituents asking me if it is possible that any positive patients already so declared could be in isolation at home. So I wanted to make that point clear for the public where they are.
Right. So thank you for that question. And I'm going to say that, yes, we do have persons that are being isolated at home. But I'm going to also explain how it is that we come about that. Because in terms of making the assessment of those persons who can be isolated at home, we would have to look at the home situation, whether or not the isolation can be facilitated, what kind of symptoms the person has, and what kind of risk factors they have. So all of those things are taken into consideration. We also look at the dislocation. Right now, we have one person that is isolated at home who lives by himself. And then we have another set of persons who, it's a family that we have in making the decision in terms of the isolation of these persons at home. Then we even had discussions with the community associations in terms of making those decisions. What we want to do, though, is that we do want to prepare the public. We want to prepare them for the fact that we are going to have positive cases that are going to be isolated at home. Because as time goes by, and we're getting there very quickly, because if we don't, a field hospital is in our plan. However, that may take some time to realize. And our priority really has to be that the sicker persons who really need to be in hospital are the ones that are accessing that kind of facility. We do have quite a right now, because in the early stages, our recommendation has, of course, would have been that everybody that you pick it up, we put them together somewhere so that we contain the disease as much as possible. As we get more and more spread, you're going to find that we're not able to have the very mildly symptomatic ones in hospital. And so we're going to have to change. And we're gradually making that change so that, we can condition persons to accept that. We recognize that we are going to have to do quite a bit of public sensitization where this is concerned, because we do have problems with stigma. We have already started with the publication of the pamphlets on what home isolation is about. We have the ones on home quarantine. So we are working on the ones in terms of what home isolation is about, and this document for sensitization of the healthcare workers, how it is that we manage home isolation. So this is something that we definitely have to plan for. We have a few of our facilities now that are full with cases that are suspected cases, not yet confirmed, but also a lot of very mildly symptomatic persons who really don't need to be in hospital.
Okay, and just let me just add to that, member Holness and others, colleagues. Remember now, based on the trajectory of the virus, the modeling that was done, as is the case with countries all over the world, you do expect a fairly large number of infected persons over time, and then after which, hopefully, the herd immunity would take effect, managed properly, and other solutions or medicines would come into effect over time to control the virus. That's the history of how these viruses work. So it was never envisioned that every single positive case would be hospitalized. They made it just not practical, and that's not the case in any country around the world. So the issue becomes, how do you create a protocol to prioritize, and what protocols, what applies to which segment of the population affected? And we have to sensitize the country to that over time. I mean, we have a projection for over 1 million infected persons over a year, most of which are going to be at home. The issue becomes, if you are so infected, what are the procedures, what are the things that have to be done? So it's a natural progression over time, which is why stigma is so important to dealing with those persons who are affected and communities in which persons who are affected reside. Member Dunn, can you speak now? You're still, your mic, something is wrong. I'm not hearing anything at all, Member Dunn.
Respond to him, don't hear that something the last time. Done.
I'm not hearing you, Member Dunn. You may need to recalibrate your mic, but the CMO wants to respond quickly to something that
right.
that you have raised.
Remember, you had made the suggestion 2 weeks ago when I had attended this committee meeting of the inclusion of the clinical pharmacist in the committee that works on the technical review of documents. And I just want to report to you that that was done, and we have 2 persons who are included in that group that do the technical review of the documents and are part of the recommendations for what it is that we use.
All right. Member Dunn, until you sort out your mic, unfortunately, I can't hear what you're saying, but I know that question was asked before. All right, members, can I just move quickly to the next presentation? Paris Lewayi is online. He's head of Mona Informatics. He has worked with a committee, an advisory committee that I had set up with the permission of the cabinet and the Prime Minister to do a number of things, to essentially give advice on how we were intending on dealing with that. And I just want to reassure the committee that we are thinking about it, putting a plan in place, but starting with the assessment or analysis of where these communities are, and then integrate the approach to solving some of these issues. So, Dr. Lewayi, are you hearing? You're ready and up and can take it from here.
Thank you, Minister. Morning, Chairman, morning, members. What we have been asked to do is to look at the patterns of the cases relative to certain at-risk and vulnerable groups across the country. And then when we look at the pattern of the cases alone, we're seeing 6 unique hotspots that are, for the most part, isolated. We don't want these to be coalescing with other hotspots, and these typically would happen along major road corridors and so on. We do see several warm spots in Westmoreland, in St. Elizabeth, and so on. But when you look at the cases by themselves, or you look at the cases relative to existing health infrastructure such as health centers, hospitals, and so on. Right now, I'm working on the locations of private clinics as well. So we create different tiers of health infrastructure to see their distribution relative to cases. But cases alone don't tell the whole picture, because we all know, and Mr. Golding pointed it out the other day, again, that not all places are the same. So Corn Peace and Kingston are vastly different from each other in terms of many different socio-demographic economic characteristics, even though both are technically hotspots on a case-only point of view. So when we begin to look at vulnerable groups, we start to look at certain age groups, we start to look at certain economic conditions, and certainly underlying health conditions. But it's really the combination of all of these. It's not one or the other, but the all. And then we begin to look at situations where an urban environment creates certain challenges as it relates to realistically and practically implementing or practicing social distancing, quarantining, curfews, and so on. But we'll get to that in a few minutes. So we can look at the population over the age of 65 or 60 or 70 or any combination that you want. I'm just illustrating here the over 65s. But again, their distribution, there are old people all over the country, but their concentrations are not uniform. In urban places like Kingston, we see a distinct uptown, downtown pattern of old versus younger people, but also in certain deep rural communities, we see a similar proportion of old people. So that's the distribution on the basis of age. But we got data from the National Health Fund in terms of where diabetics are located. So this is a distribution of diabetics across Jamaica. The pattern broadly follows where urban concentrations are. So if you have a lot of people, you have a lot of diabetics, and the pattern begins to concentrate themselves in urban places, but they're still all over the place. Similarly, we got data on hypertensives. So we know where the hypertensives are, and their patterns are similar to diabetes and obviously to the urban concentrations and so on. But now, because we're able to connect this to health infrastructure, we just use the health centers. So we look at the health center spheres of influence across the country for every single health center. And we know that the Sunrise Health Center has the most number of diabetics within its sphere of influence. And similarly, it has the most number of hypertensives within its sphere of influence. So we can scale down to health center focus as opposed to parish focus or as opposed to community focus or whatever. And we know how to resource these areas in terms of these underlying conditions. And again, this is just diabetes, hypertension. We can do any other combination of conditions as you guys see fit. But it's building out the model to try to determine these different vulnerable groups and at-risk people. So when you look at their distribution across the country, we begin to see the importance of the urban concentrations and the coexistence in urban areas. But then when we begin to combine urban areas and the characteristics of urban areas with population densities, looking at poverty conditions, we're looking at the old age concentration, looking at diabetic and hypertensive, we begin to see very interesting patterns. Norbrook may have certain high level of a proportion of old people and diabetic and hypertensive, but it doesn't have a very highly dense population, and it doesn't have a very high level of poverty. So the common letter risk in those areas are different from other parts of Kingston and other parts of Jamaica. But Kingston and St. Andrew are dominating in terms of the total composite score. We're seeing communities like Whitehall, Waterhouse, Arnett Garden, these guys popping up as high composite scores of high combination of population densities, poverty, old people, and people with diabetics and hypertensives. And that is the composite distribution. Again, it is uneven relative to the location of health infrastructure. But when we look at the health infrastructure themselves, we wanted to take this to the community scale. We wanted to see how far communities are from the nearest health center. And that was important. Communities in Crescent, St. Catherine, Treasure Beach, Grange Hill, Old Harbor Road, in between Spanish Town and Old Harbor, Priory St. Anne. These areas, on average, are far from health centers and also have relative high composite scores. So we begin to see what is the service delivery in these communities to health infrastructure. But then when we begin to factor in the cases themselves, we understand and begin to see the realities of reality. And I include a post here from Ian Bremer showing the first case in a slum in India, where social distances will be very difficult in those kind of conditions. So we have to be able to factor that in to the true capital letter risk and vulnerability modeling. So when we begin to look at vulnerability, we begin to look at the hazard itself as well as exposure. And we begin to see that of the top 50 communities in Jamaica, only 4 are outside the KMA. So again, Kingston and communities in Kingston are the most vulnerable to these kinds of impacts. And again, the models that you're about to see do not show probability of occurrence of coronavirus, but likelihood of impact of a coronavirus outbreak in those particular areas. So this is where population concentration, poverty, and comorbidities become a very important factor in looking at it. And so you see now the first vulnerability map of Jamaica at the community scale that factors in the hotspots that you saw earlier, but now weighted by population, age, and so on. And you can see that in Corn Piece in Clarendon, it's a warm spot, but not the hot spot of Kingston. And again, you begin to see how we're now differentiating now different parts of Jamaica differently. And we do the same thing with the risk that now factors in hospital and health center distribution. We're going to be doing this with private clinics today and see how the model changes. And that's the advantage of the model. The model changes as we parameterize it differently, as more cases pop up, the model responds differently to it, and therefore we can begin to see what's happening. But the observation here is that most of the highest scores observed in Jamaica, all of them are in Kingston, and all except for Whitehall, the community of Whitehall, are below halfway tree. And that tells us that these are the most at-risk areas in Jamaica, in Kingston, and we can determine our own strategies accordingly. We're seeing Port Antonio, Spanish Town, and Montego Bay pop up as the major communities in the top 50 outside the KMA. And this is the distribution of the at-risk population. So we begin to see how again, at-risk separate from vulnerable, separate from hotspots, and what those distributions look like. And again, look at Corn Piece relative to other parts of Jamaica. And again, that's a direct function of its population density and those kinds of categories. I should also explain, members, that we factored in, if you can see here in the exposure variable, points of interest. These are your markets, these are your tax offices, these are your areas where people would converge for whether it's retail activity or anything. And as a result of that variable, we began to see areas surrounding, for example, Coronation Market, Denham Town, and so on, having a different exposure and therefore risk category than similarly dense communities, but with fewer activity centers within those areas. And that has a particular implication on how you begin to determine what you do. One of the things the group decided to look at was to look at electoral divisions, because here we have the most granular scale of coordination and management. We have a counselor for each of the 250 divisions who we could imagine to be a point person in these areas to coordinate local scale responses and activities within those electoral divisions. We don't have that for every single community in Jamaica. Parish council is too big, and constituency scale is bigger than electoral division scale. So we're trying to scale down, and we're seeing Horizon Park, Hellshire, Warsaw divisions having the most, having people travel the furthest distance on average to the nearest health center. In other words, the health infrastructure, health service provision in those areas are the most challenged of all of the 250 divisions in Jamaica. And then when we begin to look at individual cases now of diabetics, we see Norbrook division having the most number of diabetics and the Mona division having the most number of hypertensives. And we throw them all together to determine the risk profile of every division in Jamaica. And we see Waterloo and Hughenden having the highest scores in the risk model. So we know Waterloo and Hughenden divisions, followed by Maxfield Park, Cashew Park, and Hagley Park have high scores. Again, all in Kingston. Outside of Kingston, we see Montego Bay Southern and Waterford division having the highest risk scores outside KMA. And again, this is the distribution of these risks by electoral divisions. Earlier, you were seeing it by community. And it's very important that, that we begin to put all of this together. So this is my final slide. We see where urban concentrations, we see where poverty becomes a very important consideration. We see where concentrations of activity, markets and so on, have a very important role. You reduce the level of activity, the model is going to adjust because of those variables will be altered as responses take hold. But the reality is that when you plan the practicalities of social distancing in very dense areas, in very poor areas that are challenged, when you look at curfews or quarantine logistics, it's a lot more difficult to implement these things in certain communities than others. And those realities have to be taken into account. All of this work, members, have been used to help guide the different parts of this little subcommittee in terms of how we look at the social work implementation, the behavioral thing, how to strategize and plan certain activities. But it's something that we believe sets us on the right path. I emphasize that these are models. The maps that you saw are just the output of the models, and it's the models that I'm trying to emphasize in this presentation. Thank you all very much.
Thank the President. Hello, thank you very much. Are you hearing me now?
Yes, sir.
So you would have, thank you very much, Paris. So you would have seen, ladies and gentlemen, the presentation, which is attempting to look at vulnerabilities in the society or vulnerable communities and individuals. And the intention here is to utilize this information or model and coordinate within this model additional information around other variables that impact vulnerabilities, as well as to coordinate with the respective ministries and agencies to determine an appropriate response. This work is going to be further built out, or is being built out, to include a response to these communities. So you're talking about local government, for example, and the role of the SDC, the community-based groups, the members of parliament and councils, of course. You're talking about, maybe labor and social security in terms of food distribution, National Health Fund in terms of medicines and how you deal with that, should it come to that. There's a public education program around, what are some of the things that are necessary in those areas, as well as nationally. So it will be accompanied by other things, and we're going to be adding to that. And there's supposed to be a presentation to the Honorable Prime Minister and a team, and the ministers who are relevant to this. Our PS here is going to be working with the permanent secretaries in the other key ministries to help to coordinate a more fulsome strategy. So I'm going to ask now for questions. Can you bring the list up so I can see the persons have?
Yes, to stop sharing.
Yes, to stop
All
sharing.
right, Paris, could you take down the slide for me, please? Take it down for me, please. Okay, great. All right, so I see Mark Golding, Member Golding, and Member Holness hands up. may I start with Member Golding since he's at the top?
Thank you,
Member
Chair.
Golding.
Thank you, Chair, and thank you, Dr. Liawai and team for that analysis, which is interesting. A question I had for him is, in terms of identifying electoral divisions that are most vulnerable, the data relating to the cases of diabetes and hypertension of persons resident in those divisions, how do you get that data? How do you know how many hypertensive or diabetic patients happen to live in a particular electoral division?
I can answer that. That information came from the National Health Fund and from we have the data of registered persons who seek help in those areas and whose prescriptions are written for those particular purposes. Member Golding?
You know, thank you. That's fine. Thank you.
Okay, great. Member Holness, you have can you unmute your mic?
In respect of the areas that are considered to be the most at risk, I note that urban areas are taken in preference to some of the rural communities. My observation, Chairman, has been that people who live in the hills of my own constituency have very little care or concern because they see themselves as rural, though they do come down into Kingston to go to the market, to go to the wholesale, to go to the pharmacies, and they take their taxis, they come down and they mingle, and then they go back into the hills. So I observed in trying to interact with them and providing stuff for them that everybody was bundled together because in their estimation, they are rural and it cannot touch them.
Right, good point, Member Holness. And I can ask Paris to comment, but before him, just to note that the strategy is not ignoring anywhere in our society. What it's doing is assessing the risk profile of individuals, so individuals with underlying conditions like diabetes and hypertension who tend to be more vulnerable, but also communities where you have concentrated clusters of populations, and then tailoring, the intention is to tailor a strategy to deal with those vulnerabilities or vulnerable communities or individuals, even while we deal with all. So the markets would be a vulnerable center because of interaction. You would have seen the Honorable Prime Minister visit Coronation Market a few days ago because of his own concerns as to what is happening there. And we are now busy discussing what are some of the measures that can be put in place with the Ministry of Local Government, who is in charge of markets, to see how we can minimize the risk of spread or deal with more containment in a context such as that one. So that's the intention of the model, to look at where those particularly vulnerable communities are and then try to develop or tailor a strategy to deal with them. Okay, thank you very much. All right, so let me go to Member Guy and then Member Dunn. Member Guy?
Thank you very much, Chairman. Dr. Paris, question. Our Minister, you answered the question that was asked. You said at National Health Fund, you got that data from the National Health Fund, okay?
Right.
Is it that data indicates which clinic these persons are being, health centers these persons are being seen, or is it their actual addresses that is done? I asked against the background, like say in my deep rural constituency then, Highgate Health Center sees patients for their diabetic hypertensive clinic who come from as far away as Windsor Castle, which falls in another electoral division, Richmond, which falls in another one, Esher, which is another electoral division, Highgate proper itself. So about 5 or 6 electoral divisions. Now, does the National Health Fund disaggregate this to say, okay, in each electoral division, we have this, that, or the other, or is it based on the clinics? Just my curiosity.
Based on addresses, Paris can correct me if I'm wrong. It's based on addresses because I think the base population is used from the electoral, from the registry, the electoral registry. Paris, you want to come in?
Absolutely. Member Guy,
Yes.
it is the address that they use when they register with the NHF.
Right.
We also do know where they go to for prescriptions, etc. But we don't use the health center, we don't use the pharmacy address, we use the actual address that each registrant uses. So yes, we do see diabetics from different areas, different communities, whatever. But we map them where they live or where they say they live.
All right, thank you.
Thank you, Member Guy. Member Don, can you communicate now? Still not hearing, you know. You want to WhatsApp me your questions and then I'll just read them out because I'm not hearing you at all. I'm not sure why. Something's wrong with your mic. You trying again? Still not hearing. WhatsApp them to me and I'll just read them out. Member Brown Burke, you're next.
Thank you. Just a very quick question. Given the importance of water, I was wondering if there was any mapping done in those areas where we had an absence or a challenge with water to determine how that would increase the vulnerability of communities.
May I, Minister?
Go ahead, Paris.
No, but I can absolutely do that. The model allows for the incorporation of those types of conditions. And with the committee's permission, I would add this to the model.
Yes.
I'd definitely love to see that.
Okay. Well, we'll follow up on that. And water is definitely a big issue.
Okay, no
All
problem.
right.
I'll do it. No problem.
I see Member Golding again. You have another question, Member Golding?
Yeah, just quickly, thank you, Chair. In response to that last issue, I'm interested to see how you would assess water supply for this purpose of mapping, because there are areas which have water infrastructure but no water in the pipes, or very low pressure, which is often not available at all. So I'm just wondering how Dr. Luai would identify where there is a water shortage for this purpose.
Again, just like the health infrastructure distribution modeling, I don't know health center A from health center B in terms of its staffing and resourcing, etc. I just know that they're there. The particular details of each infrastructure component would have to be provided for me to weight the model. So right now, I would definitely know that there's water infrastructure. I would definitely know that there are several sources of water for each infrastructure and so on. But what I would not know is any particular daily schedule or whatever. I would even know pumping capacities, but I just don't know whatever daily capacities are there. But the important thing here, Member Golding, is that as data provided, these can be incorporated very easily, very fluidly into the model, and the model will begin to adjust in real time.
I think what we may need to do is take those communities and get the data from NWC and to a lesser extent, rural water, and then overlay that into the modeling to get the sense of the riskier nature of that community, because water is actually central to the issue.
And a key thing here, excuse me, Minister, and to wrap up the answer to Mr. Golding, what we can absolutely do is to present a best case and a worst case scenario and hope that something is happening leaning towards the best case scenario. So you remove water altogether, see what happens, and you put water in permanently and you see what happens. That's what we can definitely do with the model.
Thank you very much.
Yeah, thank you. Chair, it's very important, if we're going to add water as a variable, which we must because it's critical, and I want to thank Dr. Brownberg for her point. I think it's very important that the data we use is real and accurate and not theoretical, because the reality on the ground is that there's water infrastructure in areas where they don't get water on a regular basis. Yeah.
So it will be more than the infrastructure. It may be the scheduling of water lockoffs or availability of actual water. So I get that point, and I take it very much so. All right, so Member Dunn had some questions here. For the market, could we consider areas that the vendors are from and divide up the amount of days that the market is opened over so we can limit the number of vendors on any given day? So that would mean looking at vendors who are registered, I would imagine, with the KSA or with the municipality, and then determining whether a scheduling can take place. What I'll say to that, Member Dunn, is that there is a meeting that is taking place now between Minister McKenzie and the mayors across the country, a Zoom meeting. And I know markets is central to that discussion because of the vulnerabilities markets represent. So I'm sure with the PSs who will collaborate around this strategy, that will come up as an issue. But I will certainly raise this as one of the possible solutions, which is the coordination. Okay, the other one you have is on the matter of the surgical gowns that are ordered. Are these the regular gown, or are we looking at specialized gown that covers the worker from head to toe? I guess it's the one you see on TV with that is totally covered. Maybe the CMO can comment on that. CMO.
Right. So the recommendation is the impermeable gowns, which really covers you from neck to below the knee. I just want to say that, we have to, what we're seeing is really, we have the public health advice, and then we have the response. And while it is that the recommendation in terms of the PPEs that are needed for the general use and for use in the high-risk areas are in fact the impermeable gowns, along with the mask and the gloves and the bonnets and the shoes. We do see in several countries that persons are wearing full coveralls with even the respirators, a totally in-circuit unit. And that is really far beyond the recommendation. But the fact is that there are countries that can afford to do so. Okay, and they have done so. It creates a precedence, and it makes us all look bad because we're not providing that. But we really have to have a balance, because we have to understand what is the requirement. But we also have to understand that we come under a lot of pressure because of other countries' response, because within their system, they can afford to respond in that way. So we do have what is necessary. We do have what the requirements that have been put out by the WHO for the different settings, because there is a document that outlines in each different setting what it is that you need.
All right.
And we do have those.
Okay, thank you very much. Quick question from Member Dalrymp of Filbert, who is having some issues with her system, about black tanks being available for deep rural communities who don't have water. I believe there's a program that was announced by the government to give support to communities across the country, black tanks. It's not something that falls within our purview, but to the extent that water is a problem, as we all know it is. Member Dalrymple, Filbert, I think you may want to check on that, because I believe the government did take a position around giving some support for black tanks. All right, ladies and gentlemen, I want to thank, on your behalf, Dr. Leo Wai for his presentation. As I said before, it's a start of an assessment on these vulnerable communities and individuals. We're going to work on it over the next couple of days, and then seek to collaborate with the other agencies and ministries in terms of a response. And I think it's a good start, and I think based on the questions, I don't hear any objection to the approach. So I'm assuming that members are in agreement that it's a good starting point to guide the process towards dealing with the vulnerable communities. A lot more work to be done, but nevertheless, we're thinking in that direction. I'm going to ask now, if you will, the Ministry of Labor and Social Security. I see the PS online, and a presentation was in fact submitted. I'm not sure if members have that, but maybe she could just run through quickly the issues around welfare that they have been involved in up to this point. PS, you want to take it over from there?
Yes, thank you very much, Minister. Morning, committee members. Everybody is hearing me? Just checking. Okay, good. All right, so the Ministry of Labor and Social Security, as part of our normal responsibility during times of disaster, we have been providing humanitarian support to the households in quarantine. Just for the committee members to be aware, the ministry actually chairs the Humanitarian Assistance Committee of the National Disaster Risk Management Council. So we're the lead agency to provide relief response, primarily welfare relief. Since the COVID-19 pandemic and the various measures implemented by the government, we have been providing care packages to the households. As of April 5th, we had distributed 2,231 packages. These are food packages. Chair, we actually have a report which we will be able to send by email to the various members, but I will just go through. So we provided food packages, 2,231 food packages in terms of hygiene packages. The hygiene packages comprised of toilet paper, soap, bleach in some instances, and other items as we get donated. We provided also, we made up children's packages, which we provided to households with children. In the second week, we were able to collaborate with the Ministry of Agriculture, and we got some fresh produce in terms of lettuce, tomato, bananas, and so forth, which we were able to also distribute to the households. Now, I must point out to the committee that while we know that the packages that we provide are mainly non-perishables, it is difficult for us to receive and distribute perishable items. But recognizing there is a glut from agriculture, we try to work with them to get out some of these non-perishable items. Sorry, perishable items, sorry. We also distributed water, juice, and in a few instances, diapers and formula to the families. Now, we did just about in the Bull Bay area, which was the largest community, we did 1,945 food packages, and that was done in 2 rounds of distribution. So approximately 1,000 families in each distribution got food packages. I'll just highlight for Clarendon, which is primarily corn peas, we have distributed 194 packages and 188 hygiene packages. We have done a few distribution in the other parishes. After the community-wide quarantine in Bull Bay and after corn peas, some of the lessons learned, we are more targeted in the distribution. So we've been working very closely with the Ministry of Health, Community Health personnel to identify the actual families that are in quarantine, where the entire household is in quarantine, and providing packages to those who require it. During the whole distribution exercise, I would like to highlight for the committee that we worked quite extensively with one of the committee members, Mrs. Juliet Holness, for Bull Bay. Bull Bay was a difficult area because of just the sheer size of it. We also worked with Mrs. Patricia Duncan Sutherland in the Clarendon area. We received quite a bit of donations from the private sector, and as well as Food for the Poor. Food for the Poor was very instrumental at the start in assisting us with some of the staples that we did not have in our warehouse.
That it, yes.
I don't. Okay, so we've gotten donations from private sector organization, the umbrella, JMEA, Jamaica Red Cross workers with the packaging of the items as well as the distribution, NB Foundation, Wisinco, Jamaica Biscuit Company, Lasco Distributors, Ebony Park Heart Academy, RADA, that is Ministry of Agriculture, HerFlow, HerFlow is a company that distributes sanitary napkins. Nestle Jamaica, Jamaica Private Power Company Limited, Salada Foods, Chas E. Ramson, Jamaica Macaroni Company, Pepsi, Honeybun, Jamaica Energy Partners, Meal and Massey, Jamaica Flour Mills, and Paradise Funeral Home. These are the companies that we have on record that have made donations to us. We have another company that's making a small donation to us tomorrow. Is Cal's, I don't remember their proper name, their full name, but it's Cal's. They manufacture tomato ketchup and some other food items. Now, the ministry normally has a feeding program where we provide meals to senior citizens, primarily in Kingston and St. Andrew, recognizing daily meals, Mondays to Fridays, recognizing that having seniors come out to collect a meal will increase their risk of contracting the virus. We have taken a decision to distribute food packages to them, and to date, just about 900 seniors have received food packages from us, not just in Kingston, just about 600 seniors in Kingston. And these are mainly seniors who are shut-ins and have no one else to look after them. 600 in Kingston, and in the other parishes, just about 300 persons have received. Now, this is outside of what local government may be doing with respect to seniors. These are the ones who we know are registered with the National Council for Senior Citizens. Some of the other initiatives that the ministry has undertaken, those are specific COVID related, but some of the other initiatives that the ministry has undertaken, members would be aware that the PATH payment was distributed early. It started yesterday. In conjunction with the Ministry of Education, PATH beneficiaries who are families who have children in school received a top-up that would help to cover or to say compensate for school feeding that the children would have received had school been in session. So for children in primary schools, families got $1,200 for each child, and for children in secondary schools, the families got an additional $1,500 per child in secondary school in the PATH payment. The payments, as I said before, started yesterday. There are some other activities related to PATH which we have suspended. So for the members who are MPs will know that a number of your constituents would have gotten letters from us advising them that they need to come in and to reapply for PATH because they've been on the program for quite a while and we need to do a reapplication process. We have suspended that part of the program. For the as well as the government announced that an additional benefit will be paid to PATH beneficiaries in May. we're still working with the Ministry of Education. I'm not sure if we will have the additional monies topped up for school feeding. That has not been finalized as yet, but there will definitely be another path payment in May, as well as June, which is the normal payment cycle. For the National Insurance Scheme, the NIS pension population, that is persons over 65. We have approximately 120,000 pensioners. And as of March 30th, pensioners were able to encash all pension order vouchers with payable dates in the month of April 2020. For the committee's information, this was an initiative to try and reduce the seniors coming out, because if you know, NIS payments are made fortnightly. So we allowed pensioners to collect 1 month in advance rather than coming twice in the month. This in and of itself created a bit of challenge for the post offices who didn't have adequate cash on hand to disperse to the pensioners. The other programs in the ministry continue as normal, much to my staff, not their delight, Minister Tufton, because we're supposed to be practicing social distancing and trying to limit our office, persons in the office, but we realize that we are a key ministry as it relates to the social support. Thank you.
Thank you very much. Thank you very much, Madam PS. Appreciate the presentation. All right, the floor is open. I see Member Dalrymp Filbert and then Member Guy. Member Dalrymp Filbert.
Thank you, Dr. Tufton. I've been losing the internet. It's been dropping here, so I don't even know if you got my question. I also sent it by WhatsApp. Two questions.
I got the questions on the black tab.
One, and what was your answer? I didn't hear it. Well, it fell. I lost the internet then. The other thing I wanted to suggest or to ask you if you people have considered, I know you've been testing in areas and so, but in areas like markets all over the island, have you considered just doing random testing on a market day when people are there, like getting to the Falmouth market, getting to a market where you have people gathered all over the island to get a good picture as to whether or not we have persons with the, that's testing positive or have symptoms or whatever in those areas. Because I know you're going from place to place, but when you have market days and they're crowded, people are coming in from all over and you don't really get to them.
All right, there is a testing protocol. Member Dalrymp Filbert, this CMO is here, but the testing protocol determines how tests are carried out, and it doesn't involve just not yet anyway driving to a location and just testing people in the market. It involves and let me try and see if I can get it right. I'll tell you what, CMO, you want to do it? I mean, I could start. She's having a biscuit and a piece of cheese. So let me start and then she'll come in. We test based on travel history, and we've been doing a lot of that because remember the virus is imported. We test based on links to travel history. So persons, once you do the contact tracing, you have a positive case imported from New York, then you go to those persons who have been in touch or contact, and you quarantine and you test those. We test healthcare workers because they are frontline and are at risks. We test randomly, semi-randomly, persons who have upper respiratory ailment who turn up at the health centers or the hospitals, and certainly those who are hospitalized. So that comprises the approach. Now we're going to mobilize, we're going to deploy some mobile units soon, this week. And those units are going to be out in the field. And we should, I think, use them at these high-risk gatherings like markets and they will screen persons who are interested to be tested. So persons will be assessed and then a determination made, and then the samples collected for testing. So the response to your question is that I think we will get there, right, Simo, in terms of the high-risk communities like markets. And we're hoping that we'll deploy those vehicles or those mobile units sometime this week. They're being retrofitted now to suit a particular purpose.
Okay, Dr. Tufton, I really miss.
You're going in and out. Can you repeat that? I'm not hearing you, Member Dalrymp Filbert, but if you get back on, just interrupt me. In the meantime, can we go to Member Guy, please?
Thank you, Chairman. PS Resident, just 2 quick questions. You indicated that there'd be a suspension of the program of suspending those persons who you would have been asking to come in to get a new status on their path program. So that letter that was sent out from February, May last year, and persons who have not benefited since then, you have temporarily suspended that program, so they'll still get their path benefits.
Yes, Member Guy.
Yes, okay. Secondly, Chairman and PS Resident too, but there was a concern that came from a farm worker who arrived home and was adhering to the 14-day quarantine at home. He called me that he was not able to work during the period that he has been at home, and his family is depending on him. Don't know whether he made any money abroad or not, but the fact is that he wants to know whether the state could give him some assistance during the 14-day period that he would be at home. And I'm sure it's not unique to him alone. You indicated those persons who have been in self-quarantine that they had gotten some benefits, and you indicated on your chart the respective parishes within which these persons would have resided. Question, can they contact the local office in the respective parish to see whether during this particular period they could get some assistance?
Member Guy, you are thinking assistance in what way?
Food packages, man, something like that. Even food packages as you were given to those persons in the areas that were under quarantine. He's on home quarantine.
He as an individual is on home quarantine, not the entire household.
Well, he has returned.
Remember, we have been focusing on households.
No, I think you didn't get the part of the question that I was saying.
The concern is if we.
I'm saying that he says he's the only breadwinner for his family, who depends on him. Now he's back from a country which there is community spread. He has been asked by the authorities to self-quarantine at home for 14 days. He cannot earn for his family. Is there any program of assistance, even care packages, food packages that could be given to such a family?
Can I come in here, member, just to say that to the extent that persons are quarantined, now in this case, this person just came back from the farm work program. I'm assuming, having spent some time there earning, he would have a little earning, right? But but you know, that's my judgment and speculation, which may not be accurate, but I would assume so, since they were there for some time. Beyond that, however, to the extent that someone is held, if they are held in community quarantine, as you know, as was said, we do give support. If they are held in institutional quarantine, we give support. If there are exceptional cases in home quarantine, then I don't see why we can't make a case for some support. And the health team who would visit some of these cases would pick up some of that information. And I'm sure the Ministry of Labor, that is, it would not be unwilling, having assessed a particular circumstance, to give some support. Remember though, beyond that, members of parliament, councillors, we are all given some support to provide support also. So to the extent that we know our constituents, in other words, there's no one entity. It's a all of us approach to dealing with.
Remember that money don't come at donor minister.
Sorry?
On this way, we have been told.
Right, and it's gonna come shortly, but I know you have your CDF, which gives you a little flexibility at the same time. All right. So
can I make a clarification for something
Sure.
I said earlier?
Sure.
Just to point out that Mrs. Patricia Duncan Sutherland made a donation of items to us that we distributed. I think what I said, I don't want there to be any misinterpretation of what I said, but she made a donation of items to the ministry that we distributed. We did work with the sitting member of parliament, which is Mr. Charles as well.
Right. Okay. All right. That's clear up. Thank you. All right. I see two hands. Well, a member guy just spoke. So let me go to member Brownberg, please.
Okay, thanks very much. Just very quickly, you said that you had suspended the reapplication process for the PATH beneficiaries. I wanted to know that meant that any outstanding issues that individuals had, if you have suspended also any discussion around those.
Sorry, can you repeat that, Member Brownberg? You went out a while ago.
Oh, I'm sorry about that. If there are individuals who have issues with their PATH benefits, I'm asking if you have also suspended resolving those. Can persons come in to resolve those, especially since there's going to be the additional benefit at this time?
Okay, so we have not suspended for that in terms of persons coming in to clarify or correct things. We have suspended the compliance requirement. As you know, compliance will be required for the children. School is not in session, so there would be no need for that. In terms of member, just to clarify for persons, if persons were already suspended from the program because they did not come in to reapply, those suspensions continue, right? We're not reversing those suspensions, but persons would have gotten letters to come in and they have not yet been suspended from the program. It is those persons now where we have waived that.
Okay, thank you. The second question and last question. I know that for the grants and benefits to individuals that there is actually a helpline. The specific question is whether or not you had any thinking of using your SDC, CDC, etc., to help individuals to actually submit their applications, recognizing that in some communities, there are some individuals who will be challenged to actually go online and complete their application.
Member Brownberg, we are not handling that. I think you're speaking about the compassionate grants under the program that was announced by the Minister of Finance. We're not handling that.
Minister of Labor and Social Security is not handling that.
No, we're not handling
Okay, all right. Minister, if you could tell us who's handling that, because that's a question that really requires.
Minister of Finance and Planning.
Minister of Finance and Planning. Okay, thank you. So that question is not for you, but Minister, I'd like you to take that question on board.
Can you repeat the question? Sorry.
No, just simply that there are some individuals who are going to be challenged in terms of applying online. And I was wondering if there was any thoughts to empowering the SDC, CDCs, and so on to assist in doing that.
Well, I'm sure to the extent that constituency representation, as I'm sure you are very effective in doing, can mobilize through your constituency office the support of your SDC or CDC officers to give support. That sounds to me like it's almost a logical extension of your leadership at the local level. So I will mention it, but I don't think we need a mandate to do that, because I think you're well organized enough to get that kind of assistance, and we should assist our constituents. So I support the view.
No, Minister, just to be clear, that I am already organizing such a support on the ground with volunteers, but I just thought that it's something that could be structured.
Okay. All right. Well, I'll mention that. Thank you. Thank you very much. Okay. So thank you, PS. I'm going to go to the final presentation because we're really trying to wrap up in not too long from now. The Ministry of Local Government and Community Development. I'd like you to recognize yourself and just quickly give us a brief overview, and then we take it from there. That's Ms. Lewis, I think it is.
Yes, sir. Thank you. Minister Tufton. Just to note that PS Henry Martin stepped out to be a part of the meeting you spoke about with the mayors and the Honorable Minister.
That's fine.
Okay. So the Ministry of Local Government and Community Development's response is in an effort to bolster the support to our registered poor population through the Poor Relief Department. We have on record 6,253 adult registered poor persons to whom we will be providing care packages over 2 months to help them with their nutritional needs, as well as we'll be giving a daily support to our children of $300 for 28 days. We have on record 3,885 registered poor children. That is our intervention for the outdoor poor relief clients, as well as increased social work from our poor relief officers who will be monitoring and going into the homes of our elderly to ensure that they are properly cared for at this time, especially those who are not able to go out. For our infirmaries, we embarked on an sanitization campaign that saw a mass cleaning of all our facilities, and that sanitization will be maintained through the employment of additional cleaners at all of our facilities. Also, we have a screening component where everybody entering the facility has to be screened before going in. We have also ceased all visits to the facility outside of service providers, of course, and also we are not accepting any new admissions at this time, as Minister Mackenzie would have mentioned. We have partnered with the Jamaica Fire Brigade to provide ambulance services in case it will be needed, and we have mounted additional hand washing stations at all of our facilities to increase cleanliness. We have also purchased motion hand sanitizers to be installed at all of our facilities. Our next program component is the homeless program. We have now increased our meal provision island-wide to at least 5 meals per day. And in the Kingston area, we are doing 7 meals per day. 2 meals at least for 7 days. Also on Church Street, we have retrofitted an area that will be used to accommodate homeless persons. And up to last night, we accommodated 39 persons in that facility. There's also a sanitization component where the hotspots where homeless persons are have been sanitized, and we will also be providing care packages to our homeless population. That's the major part of our intervention.
Thank you very much, Ms. Lewis. Can I ask Member Brownberg, who has her hand up, to come in here?
I'm sure, just 2 quick things. One was in terms of the shelter, the additional capacity for the homeless. I was looking at some of what was being done, and I'm a little concerned just about the testing, screening, and just the close proximity in which individuals are being housed for the temporary shelter for the homeless.
Okay.
Go ahead, Ms. Lewis, sure.
Right, so the capacity comfortably is 60 persons, and we have 2 practical nurses stationed at the facility to carry out the screening and the testing of the homeless persons.
Okay, so the second and last question has to do, you spoke about the cleansing that you were doing of the areas where some of the homeless persons normally are. And it sounds like a one-off, but this is intended, I would imagine, to be a continuous activity?
Yes, it should be, because those areas are traversed very often, so it will have to be on an ongoing basis.
Okay, thank you.
Okay, thank you very much, Member Brownberg. Is there anyone else who wants to comment on the presentation by the Ministry of Local Government? As I had said earlier, I know the minister is now meeting with mayors and discussing the response. The Ministry of Local Government has been allocated a small amount of funds to help with the town criers and the notices out in the field. And we're going to be working closer on the vulnerable communities as well with the Ministry of Labor also. So there is some coordination taking place and others to come. Ladies and gentlemen, I want to thank you and move now to any other business. If there's any matter that anyone wants to raise that has not yet been raised. Yes, Member Golding, thank you.
Thank you, Chair. Just quickly, I just want to endorse what Dr. Brownberg had said about the question of some structured approach to enable, especially our elderly, but others who may not have access to internet, and elderly persons who are not au fait with technology, to apply for the compassionate grants to which they may be eligible. Obviously, as members of Parliament, we will do what we can to facilitate that. But if some structured approach could be considered or developed through the SDC or whichever agency of government, that would enable those persons to be identified and to assist them to apply, that the members of Parliament could tie into or refer them to and so on, it would be, I think, useful. Otherwise, I fear that we may have many vulnerable persons who simply struggle to or don't benefit from it. Obviously, as members of Parliament, we're going to try and minimize that and develop in our own way whatever arrangements we can to help them. But a structured approach from government, I think, would be useful.
So I'm not disagreeing with it, Member Golding. I will raise it with the Ministry of Finance and certainly with the Ministry of Labor, and local government, given that they control the community-based entity, SDC. But just bear in mind, as I had said earlier, that the approach that the government is now taking involves a list of agencies and entities, including MPs. As you all know, we as MPs have got $2 million to our CDF. I've used my $2 million to get as much food supplies as possible. And I'm making care packages, and I'm using my political organization on the ground, use my indigent list that I have to distribute to the indigent, because they are the most vulnerable, particularly in a time like this. So to the extent that we can further extend that network that we have on the ground, whether collaborating with SDC or our own organization to assist in accessing additional support, then I'm just encouraging us to do that, because I think at this time, it's the kind of leadership that our constituents are looking towards us for.
Absolutely.
But I'll follow on the suggestion.
I mean, I would just add that in the distribution of care packages and so on, we have tried to incorporate the churches and the CDCs, the local community development committees, to try and broaden our reach and ensure there's less possibility of any accusations of unfairness and so on. But in relation to this particular issue of helping them to apply, I just want to thank you for taking it up with your colleagues. Thank you.
Thank you, sir. Member Guy and then Member Holness. Member Guy, your turn.
Thank you very much, Chairman. You're in AOB, right?
Yes, I'm on AOB.
CMO, this question is for you. You said that there were 72 samples done yesterday.
No. No, I said we received.
Oh, can you say how many samples were done yesterday? How many were tested?
Yesterday, 47.
And how many are tested on Sunday?
44.
44. And how many on Saturday?
No, sorry, correction. It's 47 on yesterday, 46 on Sunday, 44 on Saturday, and 62 on Friday.
62. And we don't have the results for Saturday, Sunday, or Monday yet.
Yes, we gave the results for each day. On Friday, we had 3 positives. On Saturday, we had no positives. On Sunday, we had 1 positive, and we're reporting. We're pending some results today.
Minister, before you jump in, CMO or PS, can either of you confirm that there are 12 positive cases confirmed at the National Influenza Laboratory on Friday?
12?
No.
We have never had 12 in one day.
No.
You can deny it then that it was given 12 results on Friday?
We have no report for, on Friday, we did a sampling of 62 tests in all. 47 were suspected cases, and 15 were from our SARI-ILI testing protocol, which makes a total of 62 tests. And of that number, we received notification from the National Influenza Center that 3 of those tests were positive.
3?
Yes.
3?
3.
But when was that? But when was that 3 given out as to the nation? I'm having some challenges with the numbers here and reconciling what was given out.
So those 3 brings us to 58.
No, I know that PS. I just want to know, when was that 3 number given to the country?
So that was given to the country on Saturday, I believe. In our public, in our PR release, in our press release. That number was issued, and no, we didn't do a press release one day, I recall, and so the numbers were added. It was 3 and 1.
That would have been 4.
And then Sunday our release was, that brings us to the, no, Sunday we released 1 positive for Sunday. That brings us to 59.
So we had a press release on the 4th that said 58 confirmed.
So, all right, fine, I understand that, and I'll work with you. But so you're basically saying, Minister, Permanent Secretary, and CMO, that you have never gotten 5 positive tests on 12 positive tests on one day at the lab.
Mr. Guy, what you may be confusing if you're getting results. What you may be confusing is that we have the repeat, so we don't report on the repeat tests.
I know I'm not confused anything, Dr. Besesa.
Okay, so in one day we may get more positive tests, but they would have been repeat tests for persons who would have started their discharge testing. So it was asked before whether or not we include the repeated tests that we do.
But you wouldn't have.
Right, but we don't include those in the cases that
That's
are
understandable.
Right, but I mean, you can see a report. I mean, if you really look at all the positives that the NIC report in one day, they would also have the repeat positives.
Right.
Yes, with those that you are planning to release, or
the new ones, in addition to the new ones.
All right.
Is
Okay.
that satisfactory? Okay. Member Holness. Not hearing you. Unmute your mic, please. Unmute your mic, please.
Hi, Minister, Chairman and members. I overheard a discussion as it relates to responding to senior citizens. I don't think I heard about the National Council for Senior Citizens. That organization also has a substantial database of the vulnerable and seniors. And I must say, just like Chairman, I'm comfortably able to assist my constituency because we do maintain a listing of those persons who are indigent, all our senior citizens, all the persons who are needy. Whatever side of the political divide they're from, it is easy for them to come out, community by community, and access the packages provided for both cleaning, sanitation, and food packages right across the board. So we are certainly not having a challenge at this time.
Thank you very much, Member Holness. Ladies and gentlemen, if there is no any other business, I want to move now to the date for the next meeting. As you know, we're moving into the holy season or holy weekend, Easter, and I want to use the opportunity to just wish for members and all online a peaceful, restful, holy Easter, and particularly our healthcare workers out there who will be working right through, just to wish them a happy season and a reflective season, and God's richest blessing and guidance will continue to be with them and all of us as we try to overcome this challenge. I thought this meeting was a good one in terms of the content and in terms of the follow-up questions. I am pleased with the approach. I know last meeting members raised the issue of the need for oneness and unity in the face of this national emergency. And I do not discern that any of us online have any other intentions but to see to the best interest of the Jamaican people. And as chair, I want to just make that clear and public for the record and encourage that continuation of approach. So in terms of the next meeting, maybe the clerk can help us. Given that Monday, is Monday a holiday? Monday is a holiday. Do we meet back on Tuesday at the same time? Is that what is being proposed? I think we could do that then. Yes? Any objections to that?
Chair, no objection.
I don't think many of us will have the opportunity to be out of town and on the beach and all that, because otherwise you may be breaching the orders. So I suspect it will be a quiet season. So we will do that then for next Tuesday. And in terms of the agenda, we will keep it fluid and advise you. We will give our regular update, and if there is some additional information that's needed, then we'll advise. I'm going to ask the clerk.
Chair, before you go, please.
Yeah.
Last meeting, the question was raised about the possibility of an amendment temporary to the Pharmacy Act in light of the fact that you're trying to, at this stage, to prevent some amount of gathering and the possibility of calling prescriptions from doctors in the private sector. Is there any likelihood that for this particular period that there could be a relaxation of that to allow the pharmacists who know the respective doctors to be protected?
I'm told that the process has started. I'll get some better particulars and be in a position to report back on that later on.
Thank you.
Member Brownberg, you had a
Yes,
comment?
sure. I just wanted to remind rather that the presentations from today's session, if they could be emailed or made available to the members, that would be helpful.
So they were all sent to the clerk. So I'm going to ask her to make them available. Okay.
Thank you.
And I'm going to, at the same time, remind the clerk about the early distribution of the minutes of the meeting, as was mentioned earlier, so we can be fully prepared for the meeting. Thank you very much, ladies and gentlemen. Appreciate the time. In a sense, you are on the records as creating history for your first Zoom meeting, appropriately so. well, should I say, let me not say Zoom and branded. Let me just say your first virtual or digital select special parliamentary committee meeting on this important COVID-19 challenge. Thanks a lot and have a good day and a good week. Thank you.
Motion, Chairman.
Motion.
So moved.
Member Guy, seconded by? Seconded by Marisa Dalrymp, Filbert, Member of Parliament, South Trelawney. Thank you very much.
Pleasure.
What can a little germs do?
Pink eye running belly, even flu. Germs can make them happen to you.
Put germs on our manners with these. Cover your mouth when you cough and sneeze. Always wash your hand with water and soap. Keep dirty hands from your eyes and your nose and your mouth. You don't want to be sick, take care. Practice every day, no germs around here. A message from the Ministry of Health.
An important message from the Ministry of Health and Wellness. How to wash your hands. Firstly, wet your hands. Then apply some soap. Rub your hands palm to palm. Lather the backs of your hands. Scrub between your fingers. Rub the backs of fingers on the opposing palms.